हेलो फ्रेंड्स, आज हम लोग बायोकेमिस्ट्री में पार्ट बी डेमोन्स्ट्रेशन पढ़ने वाले हैं, जो कि चैप्टर नंबर 30 है, जिसमें हम लोग देखेंगे बायोकेमिकल बेसिस और रेशनल ऑफ बायोकेमिकल टेस्ट्स इन वेरियस कंडीशन। तो चलिए शुरू करते हैं। विथ ए वाइड वैरायटी ऑफ बायोकेमिकल इन्वेस्टिगेशंस बीइंग डन टुडे, वी हैव टू नो व्हाट द डिफरेंट लैबोरेटरी फाइंडिंग्स और रिजल्ट्स मीन एंड व्हाई इट केम अबाउट। इतने सारे जो आजकल के बायोकेमिकल जांच होते हैं, टेस्ट्स होते हैं, क्यों होते हैं और ये कहाँ से आया, क्यों आया, ठीक है, ये सब हम लोग देखेंगे। टू हेल्प गिव सम क्लैरिटी टू द स्टूडेंट, जो ऑथर हैं वो क्या करें, ट्राई किए हैं टू एक्सप्लेन बिलो द थ्योरी बिहाइंड दी लेबोरेटरी फाइंडिंग्स इन ए वैरायटी ऑफ डिजीज एंड कंडीशंस। द लिस्ट और एक्सप्लेनेशन गिवन are not exhaustive and therefore students are requested to refer to textbooks of biochemistry and other subject also। तो इनको पढ़ने के बाद दूसरे जो सब्जेक्ट्स हैं, टेक्स्ट बुक्स हैं, उन्हें भी पढ़ना है ताकि और अच्छे से क्लियर हो। पहला है डायबिटीज मेलाइटिस, बेनेडिक्ट्स टेस्ट, यूरिनरी ग्लूकोज डिपस्टिक टेस्ट। ग्लूकोज यूरिया occurs when the renal tubular maximum for glucose has been reached with a renal threshold of 180 mg per deciliter. Glucose is filtered out into the urine. थ्रेशोल्ड 180 मिलीग्राम पर डेसीलीटर है। अगर इससे अधिक शुगर आ गया ब्लड में तो फिर वो फिल्टर आउट होकर यूरिन से निकलने लगता है। इंक्रीज्ड प्लाज्मा शुगर वैल्यू, डायबिटीज मेलाइटिस इज अ कंडीशन which occurs due to lack of insulin secretion or improper insulin action or defect in insulin receptor। 3 कारणों से होता है, या तो इंसुलिन का सिक्रेशन नहीं हो रहा है, या सही से काम नहीं कर रहा है इंसुलिन, और दूसरा इंसुलिन का रिसेप्टर खराब हो गया। सीरम इंसुलिन एंड सीरम C-peptide इन टाइप 1 डायबिटीज मेलाइटिस द सीरम इंसुलिन लेवल आर एब्सेंट और वेरी लो with an concomitant increase in glucagon level. This leads to gluconeogenesis and increased lipolysis. Presence of C-peptide in blood is an indication that the pancreas is secreting insulin. Is a part of proinsulin which is snipped off for forming mature insulin will be absent in the therapeutic insulin given to diabetic patient. सीरम इंसुलिन एंड सीरम C-peptide। तो टाइप 1 डायबिटीज मेलाइटिस में द सीरम इंसुलिन लेवल आर एब्सेंट और वेरी लो विथ a concomitant increase in glucagon level. This leads to gluconeogenesis and increased lipolysis. Presence of C-peptide in blood is an indication that the pancreas is secreting insulin. Is a part of proinsulin which is snipped off for forming mature insulin will be absent in therapeutic insulin given to diabetic patient. Increased serum and urine osmolarity due to presence of increased amount of glucose solute in blood, hyperglycemia. Due to presence of increased amount of glucose in blood, hyperglycemia, and in the urine relative to water content. Glucose is osmotically a very active body fluid solute. Note the osmolarity of the body fluid increases as the ratio of solute to water molecule increases. Ketonemia, ketonuria, positive urine Rother's test, dipstick test, usually seen in diabetes with very severe and prolonged episode of hyperglycemia. The low insulin level combined with the increased level of insulin counter hormone, catecholamine, cortisol, and growth hormone will activate hormone sensitive lipase, which will cause the breakdown of triglycerides and release of free fatty acids. The excessive free fatty acids are taken up by the liver and converted to ketone bodies that are released into the circulation. The process of ketogenesis is also stimulated by the increase in glucagon levels. leads to condition of diabetes ketoacidosis. तो कीटोनीमिया, कीटोन्यूरिया, पॉजिटिव यूरिन यूरेथ्रास टेस्ट, डिप्स्टिक टेस्ट, ये सब कब होता है? तो यूजुअली सीन इन डायबिटीज विच ए वेरी सीवियर एंड प्रोलॉन्ग्ड एपिसोड ऑफ हाइपोग्लाइसेमिया, द लो insulin level combined with increased level of insulin counter hormone, catecholamine, cortisol and growth hormone will activate hormone sensitive lipids, which will cause the breakdown of triglyceride and release of fatty acids. The excessive fatty acids are taken up by the liver and converted to ketone bodies that are released into the circulation. The process of ketogenesis is also stimulated by the increase in glucagon hormone, leads to the condition of diabetic ketoacidosis (DKA). Decreased blood and urine pH acidosis in DKA. Acidosis is due to overproduction of beta hydroxybutyric acids and acetoacetic acid, two relatively strong acids responsible for the acidosis pH. Okay, once again, in decreased blood and urine pH acidosis in DKA, यानी diabetic ketoacidosis. So acidosis is due to overproduction of beta hydroxybutyric acid and acetoacetic acid, two relatively strong acids responsible for the acidosis. At physiological pH, these two keto acids dissociates completely, and the excess hydrogen ion binds the bicarbonates blood buffer, resulting in decreased serum bicarbonate levels. Ketone bodies thus circulate in the anionic form, which leads to the development of anion gap acidosis. Electrolyte imbalance. Sodium and chloride. Initially, increased glucose concentration is restricted to the extracellular space, which forces water from the intracellular to the extracellular compartment and induces dilution of the plasma sodium concentration. Subsequently, further increases in the plasma glucose concentration will lead to osmotic diuresis with losses of water and sodium chloride in the urine, leading to further decrease in sodium level. Potassium. The presence of hyperglycemia leads to a shift of water and potassium from the intracellular to extracellular space. This shift of potassium is further enhanced in the presence of acidosis. Potassium depletion is due to excessive urinary potassium loss secondary to osmotic diuresis. Potassium depletion is due to excessive urinary potassium loss secondary to osmotic diuresis. Lipid profile. Diabetics are seen to have a clustering of interrelated plasma lipid and lipoprotein abnormalities. Diabetics are seen to have a clustering of interrelated plasma lipid and lipoprotein abnormalities, which include reduced HDL cholesterol and predominance of small dense LDL particles and elevated triglyceride levels. Increased hepatic secretion of large triglyceride-rich VLDL and impaired clearance of VLDL appears to be of central importance in the pathophysiology of dyslipidemia of diabetes, especially triglyceridemia. Lipid profile. Diabetics are seen to have a clustering of interrelated plasma lipid and lipoprotein abnormalities, which include reduced HDL cholesterol and predominance of small dense LDL particle. Lipid profile, ठीक है. Diabetics are seen to have a clustering of interrelated plasma lipid and lipoprotein. Abnormalities, which include reduced HDL cholesterol and a predominance of small dense LDL particles and elevated triglyceride levels. Increased hepatic secretion of large triglyceride-rich VLDL and impaired clearance of VLDL appears to be of central importance in the pathophysiology of dyslipidemia of diabetes, especially triglyceridemia. Glycosylated hemoglobin. The aim of diabetic management is to maintain the blood glucose concentration within or near the non-diabetic range with a minimal number of fluctuations. Plasma glucose concentration can be measured by laboratories in addition to patient self-monitoring of whole blood glucose concentration. Long-term blood glucose regulation can be followed by measurement of glycosylated hemoglobin. Glycosylated hemoglobin is the term used to describe the formation of a hemoglobin compound produced. Glycosylated hemoglobin is the term used to describe the formation of a hemoglobin compound produced when glucose, a reducing sugar, reacts with the amino group of hemoglobin. Hemoglobin या protein. A glucose molecule attaches non-enzymatically to the hemoglobin molecule to form a ketoamine. The rate of formation is directly proportional to the plasma glucose concentration. Because the average red blood cell lives approximately 120 days, the glycosylated hemoglobin level at any one time reflects the average blood glucose level over the previous 2 to 3 months. Measuring the glycosylated hemoglobin provides the clinician with a time average picture of patient's blood glucose concentration over the past 3 months. Hemoglobin A1C, HbA1c, the most commonly detected glycosylated hemoglobin, is a glucose molecule attached to one or both N-terminal variant of the beta polypeptide chain of normal adult hemoglobin. The predominant adult hemoglobin HbA consists of 2 alpha and 2 beta chains in a tetramer. Condensation with hexoses gives rise to GHB derivatives designated collectively HbA1 and HbA1A1, HbA1A2, HbA1b, HbA1c, and HbA1d. In vivo, condensation between glucose and hemoglobin occurs throughout the lifespan of erythrocytes in proportion to the circulating blood glucose concentration. The glycated hemoglobin concentration in a particular blood sample therefore reflects the mean blood glucose concentration of the preceding weeks or 2 months. Measuring of glycosylated hemoglobin has been shown to be a valuable means of monitoring long-term glycemic control in diabetes and is widely used in clinician and clinical practices. Current guidelines recommends that an HbA1c test is be performed at least 2 times a year with patients who are meeting treatment goal and who have stable glycemic control. For patients whose therapies has changed or who are not meeting glycemic goal, a quarterly HbA1c test quarterly is recommended. Method of glycated hemoglobin measurement method based on structural differences, immunoassay, polyclonal or monoclonal antibodies towards the glycated and terminal group of beta chain of hemoglobin. Polyclonal or monoclonal antibodies towards the glycated and terminal group of the beta chain of hemoglobin. Second, affinity chromatography separates based on chemical structure using borate to bind glycosylated protein not affected by other hemoglobin. दो तरीका है ना ग्लाइकेटेड हीमोग्लोबिन मेजरमेंट का। तो पहला है इम्यूनो अस्से, दूसरा एफिनिटी क्रोमेटोग्राफी। इम्यूनो अस्से में क्या करते हैं, पॉलीक्लोनल और मोनोक्लोनल एंटीबॉडीज टुवर्ड्स द ग्लाइकेटेड एंड टर्मिनल ग्रुप ऑफ द बीटा चेन ऑफ हीमोग्लोबिन। और एफिनिटिव क्रोमेटोग्राफी में सेपरेट्स बेस्ड ऑन chemical structure using borates to bind glycated protein not affected by other hemoglobin. Method based on charge difference, high pressure liquid chromatography HPLC. A form of ion exchange chromatography separates of all form of glycated hemoglobin A1A, A1B, A1C. Glycated hemoglobin values for evaluating diabetes control. Normal 4 to 6%, good control 5.5%, 5.5 to 6.8%. Good control 5.5 to 6.8, fair control 6.8 to 7.6, and poor control greater than 7.6%. Please see page 66 for more question on diabetes. Okay. Dyslipidemia. Dyslipidemia is elevation of plasma cholesterol, triglycerides, or both, or a low HDL cholesterol level that contributes to the development of atherosclerosis. Causes may be primary genetic or secondary. Both primary and secondary causes contribute to dyslipidemia in varying degree. Causes may be primary or secondary. Primary मतलब genetic. Both primary and secondary causes contribute to dyslipidemias in varying degrees. Primary causes are single or multiple gene mutations that result in either overproduction or defective clearance of triglycerides and LDL, or in overproduction or excessive clearance of HDL. Primary causes are single or multiple gene mutation that results in either overproduction or defective clearance of triglycerides and LDL. Primary causes are single or multiple gene mutation that results in either overproduction or defective clearance of triglycerides and LDL, or in overproduction or excessive clearance of HDL. But it is the secondary cause that contributes to many of the cases of dyslipidemia in adults. The most important secondary cause of dyslipidemia is a sedentary lifestyle with excessive dietary intake of total calories, saturated fat, cholesterol, and trans fats, processed food. Other common secondary causes of dyslipidemia includes diabetes mellitus, alcohol overuse, chronic kidney disease, hypothyroidism, primary biliary cirrhosis, and other cholestatic liver disease. Drugs such as thiazide, beta blockers, retinoids, highly active antiretroviral agents, cyclosporin, tacrolimus, estrogen and progestins, and glucocorticoid. Secondary causes of low level of HDL cholesterol include cigarette smoking, anabolic steroids, HIV infections, and nephrotic syndrome. Secondary causes of low level of HDL cholesterol include cigarette smoking, anabolic steroid, HIV infection, and nephrotic syndrome. Diagnosis is by measuring plasma level of total cholesterol, triglycerides, and individual lipoproteins. The reference interval of the different lipids are total cholesterol 140 to 200 mg per deciliter, HDL cholesterol 40 to 70 mg per deciliter, LDL cholesterol 50 to 130 mg per deciliter, triglycerides 60 to 150 mg per deciliter. Okay, please see chapter page 97-98 for more information. Okay, myocardial infarction. Acute myocardial infarction (AMI) is a major cause of morbidity and mortality worldwide. The highest risk of fatality occurs within the initial hour of onset of AMI. Thus, early diagnosis of cardiac ischemia is critical for the effective management of patients with AMI. The ideal cardiac enzyme or biomarker needs to be highly specific, highly sensitive, and easily detectable as early as possible in the disease process. While troponin is the most commonly used cardiac enzyme for diagnosis of myocardial infarction, others exist and are used in combination with troponin. CKMB creatine kinase is a cytosolic protein involved with CKMB creatine kinase is a cytosolic protein involved with mitochondrial phosphate transport. वेरियस मार्कर्स आर, तो क्या क्या मार्कर्स है? तो CKMB मतलब क्रिएटिनिन काइनेज इज या साइटोसोलिक प्रोटीन इन्वॉल्व विथ माइटोकॉन्ड्रियल फॉस्फेट ट्रांसपोर्ट. इट एग्जिस्ट इन 3 different dimer configuration MM, MB, BB of 2 CK isoenzymes M and B. CK isoenzyme M and B. CKMB is relatively specific for myocardial tissue and becomes a valuable tool for the diagnosis of MI. CKMB can be found in serum within 4 to 6 hours of onset of myocardial ischemia. However, it can take up to 12 hours in some patients. CKMB levels return to baseline within 36 to 48 hours. CKMB can be found in serum. CKMB can be found in serum within 4 to 6 hours of onset of myocardial ischemia. However, it can take up to 12 hours in some patients. CKMB level returns to baseline within 36 to 48 hours. Troponin. The troponin are a complex of 3 protein subunits, namely troponin C, troponin T, and troponin I, located on the thin filament of the skeletal and cardiac muscle fiber. Skeletal and cardiac muscle fiber amongst the 3, troponin I is extremely specific for the cardiac muscle and has not been isolated from the skeletal muscle. This absolute specificity makes it an ideal marker of myocardial injury. They are released into the circulation 6 to 8 hours after myocardial injury, peak at 12 to 24 hours, and remains elevated for 7 to 10 days. Myoglobin is a small cytoplasmic oxygen binding protein found in the skeletal as well as the cardiac muscle. Myoglobin is a small cytoplasmic oxygen binding protein found in the skeletal as well as cardiac muscles. It is released extremely early into the serum 1 hour after the onset of myocardial injury, peaks at 4 to 12 hours, and returns to baseline values immediately. It is released extremely early into the serum 1 hour after the onset of myocardial injury, peaks at 4 to 12 hours, and returns to baseline values immediately. Myoglobin जो है स्मॉल साइटोप्लाज्मिक ऑक्सीजन बाइंडिंग प्रोटीन है, फाउंड इन द स्केलेटल एज वेल एज कार्डियक मसल. It is released extremely early into the serum 1 hour after the onset of myocardial injury, peaks at 4 to 12 hours, and return to baseline values immediately. The major disadvantage of myoglobin is the lack of specificity to the cardiac tissue due to presence of large amount of myoglobin in the skeletal muscle. The level of myoglobin can therefore not be used as a single diagnostic marker but in conjugation with the troponins or CKMB. LDH LDH is expressed in many organs including skeletal muscles, maximal, kidney, liver, heart, lungs, and erythrocytes. LDH has 5 isoenzymes. The heart has LDH1, but it is not highly specific to the heart, and LDH1 LDH2 ratio greater than 1 is reported to be specific for AMI, but currently it is not used in the diagnosis of AMI. LDH is expressed in many organs, including skeletal muscle, maximal, kidney, liver, heart, lungs, and erythrocyte. LDH has 5 isoenzymes. The heart has LDH1, but it is not highly specific to the heart. And LDH1 LDH2 ratio greater than 1 is reported to be specific for AMI, but currently it is not used in the diagnosis of AMI. It increases within 6 to 12 hours from the onset of chest pain, peaks over 1 to 3 days, and returns to normal values within 8 to 12 days. It increases within 6 to 12 hours. It increases within 6 to 12 hours from the onset of chest pain, peaks over 1 to 3 days, and return to normal value within 8 to 14 days. Today, the only use of LDH is in distinguishing acute from subacute MI in patients who reach hospital in the late stage of the disorder with a positive troponin whose CK and CKMB values have returned to normal level. New proposed markers of AMI. Many new markers of AMI are being looked into, which singly or in combination with CKMB and CTNL helps in early diagnosis of AMI. Some of the newer markers in pipeline are as follows. First, heart type fatty acids binding protein HFABP. Second, glycogen phosphorylase isoenzyme BP. Ischemia modified albumin S100A from calcium binding proteins. Cardiac peptides irisin molecules copeptin atropine molecule. New proposed marker of AMI. Many new markers of AMI are being looked into, which singly or in combination with CKMB and CTNL helps in early diagnosis of AMI. Some of the newer markers in pipeline are as follows. First, heart type fatty acid binding protein. Heart type fatty acid binding protein. दूसरा glycogen phosphorylase isoenzyme BP. Glycogen phosphorylase isoenzyme BP. Ischemia modified albumin S100A from calcium binding protein S100A from calcium binding protein. और फिफ्थ कार्डियक पेप्टाइड्स आयरिसिन molecule copeptin atropine molecule. Upper limits of normal and hours from onset of infarction. Myoglobin total CKMB troponin 1 LDH myoglobin 6 total CK 6 troponin का 5.5 CKMB 4.2 LDH 4 hours myoglobin 24 hours CK total CK 80 hours CKMB 70 hours troponin 160 LDH 160. Renal failure. Sometimes the kidney are no longer able to perform their function of filtering and clearing the blood. This can cause unsafe level of waste products to build up in the body. This condition is known as kidney or renal failure. The term kidney failure becomes manifest only when the kidney are functioning at less than 15% of normal, or when the GFR become less than 15 ml per minute, 173 mm square. Previously, renal failure was divided into either acute renal failure (ARP) or chronic renal failure (CRP). These terms CRF. These terms indicates the rate at which which damages occurs rather than the mechanism by which it occurs. The commonly used term acute and chronic renal failure (ARF CRF) has now been replaced by acute kidney injury (AKI) and chronic kidney disease (CKD). Biochemical characteristics of changes in renal disorder. Biochemical characteristics of changes in renal disorder. Retained nitrogenous metabolites, urea, cyanate, creatinine, guanidine compounds, middle molecules, uric acid. Retained nitrogenous metabolites, urea, cyanate, creatinine, guanidine compounds, middle molecule, uric acids. Fluid, acid base and electrolyte disturbances. Fluid, acid base and electrolyte disturbance. Retained nitrogenous metabolites, urea, cyanate, creatinine, guanidine compound, middle molecule, uric acids. Fluid, acid base and electrolyte disturbance. Fixed urinary osmolarity, metabolic acidosis, decreased blood pH, bicarbonate, hyponatremia or hypernatremia, hypokalemia or hyperkalemia, hyperchloramia, hypokalemia, hyperphosphatemia, hypermagnesemia. Fixed urine osmolarity, metabolic acidosis, decreased blood pH, bicarbonates, hyponatremia, hypernatremia, hypokalemia, hyperkalemia, hyperchloramia, hypokalemia, hyperphosphatemia, hypermagnesemia. Carbohydrate intolerance, insulin resistance, hypoglycemia may also occur. Plasma insulin normal or increased delayed response to carbohydrate loading, hyperglucagonemia. Carbohydrate intolerance, insulin resistance, hypoglycemia. Hypoglycemia may also occur in plasma insulin normal or increased delayed response to carbohydrate loading, hyperglucagonemia. Abnormal lipid metabolism. Abnormal lipid metabolism, hypertriglyceridemia, decreased high density lipoprotein cholesterol, hyperlipoproteinemia. Altered endocrine function, secondary hyperparathyroidism, osteomalacia. Secondary hyperparathyroidism, osteomalacia, secondary to abnormal vitamin D metabolism, hyperreninемia and hyperaldosteronism. Hyporeninемia, hypoaldosteronism, decreased erythropoietins production, altered thyroxine metabolism, gonadal dysfunction, increased prolactin and luteinizing hormone, decreased testosterone. Depending on the severity and the location of the renal damage, depends the finding in blood urine when tested. finding in blood and urine when tested. Before interpreting the reason behind the result that we get, let's recapitulate the function of the kidney and the reabsorption secretion in different part of the nephron. Important component of kidney function: filtration, preparation of an filtrate, reabsorption, glucose, amino acids, electrolyte, protein, homeostatic, extracellular volume, acid base status, blood pressure, electrolyte, metabolic, synthetic, glutathione, glyconeogenesis, ammonia, catabolic hormones, cytokines, endocrine, erythropoietin synthesis, activation of vitamin D, urinary disease. Metabolic functions of the different parts of the nephron: proximal loop of Henle, distal tubules, collecting duct. Metabolic function of the different parts of the nephron: urea loop of Henle, S plus means secretion, R for reabsorption, plus indicates function, plus indicates partial function. लूप ऑफ हेनले में यूरिया का सिक्रेशन होता है और कलेक्टिंग डक्ट में रिएब्जॉर्प्शन. प्रोटीन कहीं कुछ नहीं, तो पेप्टाइड्स कहीं कुछ नहीं, फॉस्फेट्स, सल्फेट्स. अच्छा. यूरिया का रिएब्जॉर्प्शन, प्रोटीन का रिएब्जॉर्प्शन प्रोक्सिमल में होता है. प्रोक्सिमल में यूरिया, प्रोटीन, पेप्टाइड, फॉस्फेट, सल्फेट का रिएब्जॉर्प्शन हो जाता है. ऑर्गेनिक एनायन लूप ऑफ हेनले में जो है रिएब्जॉर्प्शन होता है. यूरेट्स प्रोक्सिमल में रिएब्जॉर्प्शन, फिर सिक्रीशन. सोडियम का रिएब्जॉर्प्शन प्रोक्सिमल में होता है, लूप ऑफ हेनले में रिएब्जॉर्प्शन होता है, डिस्टल ट्यूब्यूल में भी होता है और कलेक्टिंग डक्ट में भी. क्लोराइड्स का भी सेम है, सब जगह से रिएब्जॉर्प्शन होता है, प्रोक्सिमल, लूप ऑफ हेनले, डिस्टल ट्यूब्यूल और कलेक्टिंग डक्ट. वाटर रिएब्जॉर्प्शन प्रोक्सिमल में, उसके बाद लूप ऑफ हेनले में, फिर कलेक्टिंग डक्ट में. पोटेशियम प्रोक्सिमल में, उसके बाद लूप ऑफ हेनले में, फिर सिक्रीशन होता है, पार्शियल सिक्रीशन पोटेशियम का लूप ऑफ हेनले, और सिक्रीशन होता है डिस्टल ट्यूब्यूल में, कलेक्टिंग डक्ट में रिएब्जॉर्प्शन. हाइड्रोजन आयन सिक्रीशन होता है प्रोक्सिमल में और लूप ऑफ हेनले में भी हाइड्रोजन आयन का सिक्रीशन, डिस्टल ट्यूब्यूल में भी हाइड्रोजन आयन का सिक्रीशन और कलेक्टिंग डक्ट में भी हाइड्रोजन आयन का सिक्रीशन. कलेक्टिंग डक्ट में रिएब्जॉर्प्शन भी है. बाइकार्बोनेट्स में प्रोक्सिमल में रिएब्जॉर्प्शन, लूप ऑफ हेनले में रिएब्जॉर्प्शन, डिस्टल ट्यूब्यूल में रिएब्जॉर्प्शन और कलेक्टिंग डक्ट में सिक्रीशन. अमोनिया सिक्रीशन होता है प्रोक्सिमल में, रिएब्जॉर्ब होता है लूप ऑफ हेनले में और कलेक्टिंग डक्ट में रिएब्जॉर्ब होता है और सिक्रीशन होता है कलेक्टिंग डक्ट में. कैल्शियम प्रोक्सिमल में रिएब्जॉर्प्शन, लूप ऑफ हेनले में रिएब्जॉर्प्शन, डिस्टल ट्यूब्यूल में रिएब्जॉर्प्शन, कलेक्टिंग डक्ट में रिएब्जॉर्प्शन. टेबल 24 मैनिफेस्टेशन, इन्वेस्टिगेशन और रैशनल. मैनिफेस्टेशन क्या है? साइन सिम्टम ऑफ यूरेमिया, स्वेलिंग अराउंड आईज, लोअर लिम्स. साइन सिम्टम ऑफ यूरेमिया, स्वेलिंग अराउंड आईज एंड लोअर लिम्स, फैटिग, वेट लॉस, लॉस ऑफ एपेटाइट, ये सब. इन्वेस्टिगेशन: यूरिया क्रेटिनिन, यूरिक एसिड, यूरिया क्रेटिनिन, यूरिक एसिड. रैशनल: mechanism for the regulation of electrolyte, nitrogenous waste and organic acids are similar although not identical. Anemia, hemoglobin estimation. एनीमिया में हीमोग्लोबिन देखते हैं. रेशनल्स क्या है? तो द etiology ऑफ एनीमिया, The etiology of anemia is multifactorial. A major cause, however, is the loss of peritubular fibroblasts within the renal cortex that synthesizes erythropoietin. Failure of EPO production in the kidney leads to inappropriately low concentration within the blood for the convenient hemoglobin concentration. Other causes of anemia includes absolute or functional iron deficiency, folic acid and vitamin B12 deficiency, infections and chronic inflammation. Deranged sodium, potassium chloride, bicarbonate level and water level. Electrolytes ABG. Electrolyte ABG sodium reabsorption. Sodium reabsorption is required for the reabsorption of water in many solids. Approximately 60% of filtered sodium is reabsorbed in the proximal tubules in an energy-dependent manner, driven by basolateral sodium potassium ATPase pump. Approximately 80% of sodium entering proximal tubular cells does so in exchange for hydrogen ion secretion facilitated by apical sodium hydrogen exchange. This process in turn permits bicarbonate's reabsorption via bicarbonate anhydrase. A variety of apical sodium transporter also allow for reabsorption. Other organic and inorganic solids, example chloride, calcium, phosphates, bicarbonates, sulfates, glucose, urea, amino acids. Approximately 90% of daily potassium loss occurs via renal elimination. Potassium is freely filtered across the glomerulus and normally is almost completely reabsorbed in the proximal tubules. Most regulatory mechanism affects the loop of Henle, the distal tubule and the collecting duct. Proteinuria. Urine protein, 24-hour urinary protein estimation. Serum protein and albumin. Approximately 10 kg per day of protein is presented to the globular filtration barrier, with only approximately 1 gram passing into the proximal tubule. Glomerular selectivity to protein is a function of integrated action of endothelial cells, the GBM, and the podocytes. The tubular reabsorption process is saturable. Any increase in filtered load caused by glomerular damage, increased glomerular vascularity, permeability, increased inflammatory response, or increased circulating concentration of low molecular weight proteins, or decrease in reabsorptive capacity caused by tubular damage can result in increased urinary protein loss, proteinuria. The tubular reabsorptive process is saturable. Any increase in the filtered load caused by glomerular damage, increased glomerular vascular permeability, example inflammatory response, or increased circulating concentration of low molecular weight protein, or decrease in reabsorptive capacity caused by tubular damage can result in increased urinary protein loss, proteinuria. Bone resorptions, phosphate retentions, vitamin D3 serum phosphates, vitamin D3 serum phosphate, bone resorptions, phosphate retention, vitamin D3 serum phosphate. The kidney are primarily responsible for producing 1,25-OH2-D3 from 25-hydroxycholecalciferol as a result of the action of the enzyme 25-hydroxycholecalciferol 1-alpha-hydroxylase found in proximal tubular epithelial cells. Headache, visual disturbance, check blood pressure, damages to the JGA leading to disturbance of renin, angiotensin, aldosterone system. Calcium. Serum calcium estimation. Serum reabsorption is predominantly a passive process linked to active sodium reabsorption. Approximately 98% of filtered calcium is reabsorbed, 65% to 75% in the proximal tubule via a paracellular pathway, 20 to 25% in the thick ascending limb of the loop of Henle, 10% in the distal tubule, and finally a small amount in the collecting duct. Nephrotic syndrome. Nephrotic syndrome is the clinical manifestation of glomerular diseases associated with heavy nephrotic range proteinuria. Nephrotic range proteinuria is defined as proteinuria greater than 3.5 gram per 24 hour or a urine protein creatinine ratio greater than 2. Urine protein is to creatinine ratio greater than 2. The triad of clinical findings associated with nephrotic syndrome arising from the large urinary losses of protein are hypoalbuminemia 2.5 gram per deciliter, edema and hyperlipidemia, cholesterol greater than 200 milligram per deciliter. Table 25 urine exam proteinuria 3+, 4+, microscopic hematuria, fat, lipid globules due to an increased permeability of the glomerular capillary wall, which leads to massive proteinuria and hypoalbuminemia. There is excessive effacement of the podocyte. There is extensive effacement of the podocyte and loss of this barrier to protein, allowing excessive serum albumin to leak into the urine. Some of the elevated serum lipoproteins are filtered at the glomeruli, leading to lipiduria and the classical finding of oval fat bodies and fatty casts in the urine sediment. जनरलाइज्ड इडीमा, इसमें दो चीज़ आता है, यूरिन एग्जाम प्रोटीनूरिया, माइक्रोस्कोपिक हेमेटोरिया, फैट, लिपिड ग्लोब्यूल्स। फिर है सीरम एल्बुमिन लेस देन 2.5 ग्राम पर डेसीलीटर. द नेफ्रोटिक रेंज proteinuria leads to a fall in the plasma protein level. The nephrotic range proteinuria leads to a fall in the plasma protein level with a corresponding decrease in intravascular oncotic pressure. This leads to leakage of plasma water into the interstitium, generating edema. As a result of reduced intravascular volume, there is increased secretion of vasopressin and arterial natriuretic factor, which along with aldosterone results in increased sodium and water retention by the tubules. The nephrotic range proteinuria leads to a fall in the plasma protein level with a corresponding decrease in intravascular oncotic pressure. This leads to leakage of plasma water into the interstitium, generating edema. generating edema as a result of reduced intravascular volume. As a result of intravascular volume, there is increased secretion of vasopressin and arterial natriuretic factor, which along with aldosterone results in increased sodium and water retention by the tubule. Hyperlipidemia, serum cholesterol greater than 200 mg per deciliter, triglyceride increase and increased LDL and VLDL. Hyperlipidemia is a classical feature of the nephrotic syndrome. It is related to the hypoproteinemia and low serum oncotic pressure of nephrotic syndrome, which then leads to reactive hepatic protein synthesis, including of lipoproteins. In addition, reduced plasma levels of lipoprotein lipase results in diminution of lipid catabolism. Bone pain, low bone density, serum calcium, serum vitamin D. Hypocalcemia is common in the nephrotic syndrome, but rather than being a true hypocalcemia, it is usually caused by low serum albumin level, non-ethylase, low bone density, and abnormal bone histology. Low bone density and abnormal bone histology are reported in association with nephrotic syndrome. This could be caused by urinary losses of vitamin D binding protein with consequent hypovitaminosis D, and as a result reduced intestinal calcium absorption. 6. Gout is a painful and potentially disabling form of arthritis that is very painful and is due to an accumulation of urates crystals in the synovial fluid, which leads to inflammation in the joint. Gout presenting as site redness in the metatarsophalangeal joint of the big toe, arms and hands of a 50-year-old man, showing large tophy of sodium urate affecting the elbow, knuckles and finger joint. Table 26. Serum uric acid. Hyperuricemia due to primary and secondary causes. Hyperuricemia due to primary and secondary causes. Primary gout. Idiopathic increased production of uric acid due to inherited enzyme defects. A 5-phosphoryl-aminotransferase enzyme, active but not responsive to feedback regulation, leads to overproduction of purine nucleotide, abnormal PRPP synthetase, increased production of PRPP, HGPRT deficiency, decreased activity of salvage pathway, decreases purine reutilization, increased uric acid. Serum uric acid. Hyperuricemia due to primary and secondary causes. तो प्राइमरी गॉट कैसे होता है? पहला आइडियोपैथिक और दूसरा है इंक्रीज्ड प्रोडक्शन ऑफ यूरिक एसिड ड्यू टू इनहेरिटेड एंजाइम डिफेक्ट, एंजाइम में गड़बड़ी के कारण. पहला है 5-phosphoryl-aminotransferase enzyme, active but not responsive to feedback regulation, leads to overproduction of purine nucleotide. B. Abnormal PRPP synthetase, increased production of PRPP. C. HGPRT deficiency, decreased activity of salvage pathway, decreases purine reutilization, increased uric acids. Glucose 6-phosphatase deficiency, von Jurki's disease. Glucose 6-phosphate cannot be converted to glucose. Glucose 6-phosphate cannot be converted to glucose. More glucose channeled into HMP shunt pathway increased production of ribose 5-phosphate, increased formation of PRPP. D नंबर है ग्लूकोज 6-phosphate deficiency. Von Jurgen's disease, glucose 6-phosphate cannot be converted to glucose. More glucose channeled into HMP shunt pathway. Increased production of ribose 5-phosphate, increased formation of PRPP. इसके बाद सेकेंडरी गॉट कैसे होता है? मे बी ड्यू टू इंक्रीज्ड प्रोडक्शन और रिड्यूस्ड एक्सक्रीशन रेट ऑफ यूरिक एसिड. इंक्रीज्ड प्रोडक्शन और रिड्यूस्ड एक्सक्रीशन रेट ऑफ यूरिक एसिड. फर्स्ट, इंक्रीज्ड टर्नओवर और प्रोडक्शन ऑफ न्यूक्लिक एसिड्स. ए रैपिडली ग्रोइंग मैलिग्नेंट टिश्यूज, ल्यूकेमिया, लिम्फोमा, पॉलीसिथेमिया, सोरियासिस. तो ल्यूकेमिया, लिम्फोमा, पॉलीसाइथेमिया, सीरोसिस. कैंसर पेशेंट ऑन ट्रीटमेंट यूजिंग रेडियोथेरेपी और केमोथेरेपी इंक्रीज्ड सेल टर्नओवर. कैंसर पेशेंट जो होते हैं ऑन ट्रीटमेंट यूजिंग रेडियोथेरेपी एंड केमोथेरेपी इंक्रीज्ड सेल टर्नओवर. सी इंक्रीज्ड टिश्यू डैमेज ड्यू टू ट्रॉमा और इंक्रीज्ड कैटाबॉलिज्म इन स्टार्वेशन. reduced excretion rate, renal failure, reduced excretion rate, renal failure. Intake of thiazide diuretics inhibit tubular secretion of uric acid. Intake of thiazide diuretics inhibit tubular secretion of uric acid. Synovial fluid examination. Under the microscope, birefringent sodium urate crystals seen in the synovial fluid as a small brown needle-like crystals. Synovial fluid examination. Under the microscope, birefringent sodium urate crystal seen in the synovial fluid as a small brown needle-like crystal. Okay, synovial fluid examination. Under the microscope, birefringent sodium urate crystals seen in the synovial fluid, a small brown needle-like crystals. Proteinuria, random spot 24-hour urine protein estimation. Normally, daily protein loss is less than 150 mg per day. Proteinuria may be classified on the basis of amount of protein lost as first, heavy proteinuria, moderate proteinuria, minimal proteinuria. The different causes are: first, heavy proteinuria more than 4 grams per day. Nephrotic syndrome as a result of any renal infection. Nephrotic syndrome as a result of any renal infection. Nephrotic syndrome as a result of any renal infection. Acute rapidly progressive glomerulonephritis, chronic glomerulonephritis, diabetes mellitus. Moderate proteinuria 1 to 4 ग्राम पर डे. 4 ग्राम से ज़्यादा लॉस हो रहा है प्रोटीन तो उसको हेवी बोलेंगे, और 1 से 4 ग्राम पर डे तो मॉडरेट प्रोटीनुरिया है. तो ये कब होगा? रीनल इन्फेक्शन, नेफ्रोस्क्लेरोसिस, मल्टीपल माइलोमा, प्रेजेंस ऑफ कैलकुली, टॉक्सिक नेफ्रोपैथी. मिनिमल प्रोटीनुरिया लेस देन 1 ग्राम पर डे. क्रॉनिक पाइलोनेफ्राइटिस, नेफ्रोस्क्लेरोसिस, congenital disease. Example: polycystic kidney, postural proteinuria. Proteinuria is due to an increased permeability of the glomerular capillaries wall, which leads to passive proteinuria and hypoalbuminemia. There is extensive effacement of the podocytes and loss of this barrier to protein, allowing excessive serum albumin to leak into the urine. 8 number, jaundice. Jaundice or icterus is a physical sign characterized by a yellow appearance of the skin, mucous membrane, and sclera conjunctiva caused by bilirubin deposition. Table 28. Prehepatic hemolytic jaundice, hepatocellular jaundice, obstructive or post-hepatic jaundice, prehepatic and hemolytic jaundice. कंजुगेटेड बिलिरुबिन जिसको डायरेक्ट बोलते हैं नॉर्मल रहेगा. अनकंजुगेटेड बिलिरुबिन 4+ अल्कलाइन फॉस्फेट नॉर्मल, AST normal, GGT normal, bile salt in urine absent, conjugated bilirubin absent, urobilinogen present, stool dark मिलेगा, urobilinogen 3+ present रहेगा. मतलब हेपेटोसेलुलर जॉन्डिस यानी कि लीवर में कुछ गड़बड़ी है तो कंजुगेटेड बिलिरुबिन प्रेजेंट और एब्सेंट हो सकता है. अनकंजुगेटेड बिलिरुबिन प्रेजेंट एब्सेंट हो सकता है. ALP 1+ और 1- ना प्रेजेंट रहता ही है. 1+ और माइनस करना है. ALP जो है हेपेटोसेलुलर जॉन्डिस में 2 to 3 टाइम्स बढ़ा रहेगा अल्कलाइन फॉस्फेट. SGPT, SGOT, AST, ALT 3 times increased. GGT 1+ 1-. Bile salt in urine initially absent, present later. Bile salt यूरिन में इनिशियली एब्सेंट रहेगा, लेटर में प्रेजेंट रहेगा. कंजुगेटेड बिलिरुबिन यूरिन प्रेजेंट, यूरोबिलिनोजेन इनिशियली एब्सेंट, लेटर स्टेज प्रेजेंट. ऑब्स्ट्रक्टिव और पोस्ट हेपेटिक जॉन्डिस, कंजुगेटेड बिलिरुबिन 3+, अनकंजुगेटेड बिलिरुबिन नॉर्मल. ALP 10 से 15 गुना बढ़ा रहेगा. 10 to 15 टाइम्स इंक्रीज्ड. AST, ALT लेस देन 3 टाइम्स. GGT 3+. इंट्राहेपेटिक कोलिस्टेसिस. Bile salt in urine present, conjugated bilirubin present, urobilinogen absent, stool clay colored frothy. स्टूल जो है क्ले कलर का रहता है, फ्रादी रहता है. Acute pancreatitis is an acute inflammatory condition of the pancreas that may have a self-limiting short course but can be fatal. The patient invariably presents with acute abdominal pain. Acute pancreatitis is an acute inflammatory condition of the pancreas that may have a self-limiting short course but can be fatal. The patient invariably presents with acute abdominal pain. The patient invariably presents with acute abdominal pain. Laboratory investigations. Serum lipase. Serum lipase measurement is the recommended biochemical test to diagnose acute pancreatitis. After an attack of acute pancreatitis, serum lipase activity increases within 4 to 8 hours, peaks at about 24 hours, and decreases within 7 to 14 days. 7 to 14 days. Serum amylase. Blood amylase activity is a physiological low and constant and greatly increased in acute pancreatitis. Blood amylase activity. Serum amylase. Serum amylase. Blood amylase activity is physiological low and constant and greatly increases in acute pancreatitis and salivary gland inflammation. Serum amylase. Blood amylase activity is physiologically low and constant but greatly increases in acute pancreatitis and salivary gland inflammation. In acute pancreatitis, a rise in serum amylase activity occurs within 5 to 8 hours of symptom onset. Activities typically return to baseline by the third or fourth day. A 4 to 6 fold increase in amylase activity above the normal upper limit is usual, with maximal concentration attained in 12 to 72 hours. Edema or edema. Edema is an abnormal accumulation of interstitial fluid caused by a variety of conditions like generalized fluid retention or localized reactions to trauma and allergies. edema क्या है? तो एक abnormal accumulation है interstitial fluid का. interstitial fluid जो है वो जमा हो जाता है abnormal बहुत ज़्यादा, caused by a variety of conditions like generalized fluid retention or localized reaction to trauma and allergy. Edema may manifest with swelling of the extremities, peripheral edema, or with internal fluid accumulation in organ and body cavities. Example: pulmonary edema, pleural effusion. Patients with peripheral edema usually present with painless swelling of the lower legs with pitting edema. Patients with peripheral edema usually present with painless swelling of the lower leg with pitting edema. Patients with peripheral edema usually present with painless swelling of the lower legs with pitting edema. Patients with peripheral edema usually present with painless swelling of the lower legs with pitting edema. There are many causes of edema, both physiological prolonged standing and pathological liver cirrhosis, etc. Laboratory investigations. Assay of total protein albumin globulin A by G ratio. Due to very low level of albumin, there is a decrease in the intravascular oncotic pressure. Due to very low level of albumin, there is a decrease in the intravascular oncotic pressure. This leads to leakage of plasma water into the interstitium, leading to edema. Thyroid disorders. To detect disorders of the thyroid, we perform the thyroid function tests. It consists of the following assay: T3 and T4 assay, free T3 and free T4 assay, TSH assay, thyroid antibodies, antibodies to thyroperoxidase, anti-TPO. Table 29. Primary hypothyroidism. Table 29. Primary hypothyroidism. Primary hypothyroidism. TSH high, FT3, FT4, T3, T4 low, seen in iodine deficiency, goiter, Hashimoto's disease, thyroiditis, anti-TPO increased. Primary hypothyroidism. TSH high, FT3, FT4, T3, T4 low, seen in iodine deficiency, goiter, Hashimoto's disease, thyroiditis, anti-TPO increased. Primary hypothyroidism. TSH high, TSH में FT3, FT4, T3, T4 ये सब लो रहेगा और TSH हाई रहेगा. सीन इन आयोडीन डिफिशियंसी, गोइटर, हाशीमोटोज डिजीज, थायराइडाइटिस, एंटी-TPO इंक्रीज्ड. प्राइमरी हाइपरथायराइडिज्म, अब हाइपो है और ये हाइपर. प्राइमरी हाइपरथायराइडिज्म TSH लो रहेगा और FT3, FT4, T3, T4 हाई रहेगा. Seen in Graves' disease, toxic multinodular goiter and toxic adenoma. Acid-base disorder. ABG parameters: pH, PCO2, PO2, HCO3. Metabolic acidosis, pH low, HCO3 minus. Metabolic alkalosis, metabolic acidosis. Acid-base disorder ना ABG parameter pH, partial pressure of CO2, partial pressure of O2, HCO3. Metabolic acidosis pH लो रहेगा, HCO3 माइनस यानी कार्बोनेट्स जो है वो भी लो रहेगा. लैक्टिक एसिडोसिस, शॉक इन्फेक्शन डायबिटिक में होता है. कीटो एसिडोसिस, रीनल फेलियर, रीनल ट्यूबुलर एसिडोसिस. मेटाबॉलिक अल्कालोसिस पीएच हाई रहेगा, SCO3 हाई रहेगा. वोमिटिंग, हाइपोकैलेमिया. एग्जाम्पल डायूरेटिक्स, एक्सेसिव अल्काली ड्रग सच एज फॉर एसिड डिस्पेप्सिया. रेस्पिरेटरी एसिडोसिस, pH low, PCO2 increased. Depression of the central respiratory center by cerebrovascular disease or drugs. Inability to ventilate adequately due to neuromuscular disease. Example myasthenia gravis, amyotrophic lateral sclerosis, Guillain-Barré syndrome, muscular dystrophy, airway obstruction related to asthma or exacerbation of chronic obstructive pulmonary disease, COPD. Depression of central respiratory center by cerebrovascular disease or drugs. डिप्रेशन ऑफ द सेंट्रल रेस्पिरेटरी सेंटर बाय cerebrovascular disease or drug. Depression of central respiratory center by respiratory acidosis, pH low, partial pressure CO2 high. Depression of central respiratory center by cerebrovascular disease or drugs. Inability to ventilate adequately due to neuromuscular disease. Example: myasthenia gravis, amyotrophic lateral sclerosis, Guillain-Barré syndrome, muscular dystrophy, airway obstructions related to asthma or exacerbation of chronic obstructive pulmonary disease (COPD). Respiratory alkalosis, pH greater, partial pressure of CO2 low. Respiratory alkalosis results from hyperventilation. Example: anxiety, stroke, meningitis, altitude, pregnancy के केस में इस तरह से होता है। चलिए मिलते हैं नेक्स्ट वीडियो में नेक्स्ट चैप्टर के साथ, चैप्टर 31 सीरम प्रोटीन इलेक्ट्रोफोरेसिस। तब तक के लिए भाई पढ़ते रहिए, मुस्कुराते रहिए। थैंक यू।